So, going through HIV, today, just in the interest of time and everything, mainly we'll be focusing on HIV itself. In a later session, hopefully in a couple of weeks, once it cycles over to me again, I want to do a bit on some other gum stuff, so chlamydia, gonorrhea, and so on, and I'll throw in a bit on the HIV-associated infections. Fortunately, there's not an awful lot we need to know about them, but I thought it'd be best to dedicate an entire session to HIV this time, because it's a pretty big topic, and we're all going to see it regardless of what we go into. So, just to start off with a general question, what can HIV be transmitted in? So we know RNA retrovirus goes for CD4 positive cells, that stuff. But in terms of transmission, what things? Blood is an important one. Yep. So blood is a huge one. Basically, if it's blood-to-blood contact, that's the highest rate of transmission. What other, essentially, fluids? Semen's a really important one as well. So semen, vaginal fluids. So those are the biggest ones. What things do people worry that it might be transmitted by? What fluids, for example, which the risk is actually not there? It's perfect, not in saliva. So saliva, for example, is one which people might worry about. So there are lots of fluids, unless they're contaminated by blood. So, for example, saliva, if somebody's got a cut inside their mouth or an ulcer, then possibly they can transmit it. If not, then the chance is practically non-existent. So, just real quick, we've got an RNA retrovirus. Remember, there are two species of HIV. HIV-1 is the one which is global, the one that you'll mainly see here, whereas HIV-2 is less severe and is mainly in West Africa. However, you can get infected with both. That's a HIV superinfection, and it's not good because the genetic variability means that it's very unpredictable. We don't have a vaccine because it's got a huge very fast replication rate with a lot of genetic variability. And whilst it can infect macrophages, CD8 positive cells, and a few other cells, is taking out the T helper cells, the CD4 cells, that causes the most problems and is the reason for its absolute destructive potential. It's essentially taking out the conductor of an orchestra. So like Prina and Christina said, blood and semen are the most common fluids, as well as vaginal fluids. People worry about things like saliva or sputum or nasal secretions. Essentially any other bodily secretion, unless it is contaminated by blood, isn't a transmission risk. So, how infectious is HIV? On a scale of norovirus to, I don't know, TB, where you have to be around the person for quite a lot. Perfect. Like Christine said, it's actually not very infectious. So, got this table here, and you can see that actually, if it's a blood transfusion, you've got a 90% chance of getting it. And if you're a child who's born to a mother with HIV, so vertical transmission, it's also significant. But after that, the other methods of transmission all have less than a 1 in 100 chance of passing on HIV. So IV needle sharing is about 0.2% percutaneous, so things like tattooing is 0.3. And while sex is the most common method of transmission of HIV, the actual transmission rates aren't that high. It's just obviously because sex is something which is so common compared to stuff like IV needle sharing or blood transfusions or giving birth to a child, that it's the reason for it being the path of most transmission. And you can see that generally the receptive partner during sex has a higher risk, whereas the insertive partner has some risk, but usually nowhere near as much. And this is all without condoms. There are other factors which affect the transmission of HIV. Genital ulcers is a huge one. So if the receptive partner during sex has a genital ulcer, that increases their risk of transmission by 5 times, which is a staggering amount. So let's talk about the course of the disease. So when a person gets infected with HIV, what are the two possibilities of, well, how they present, or if they present? There's really two ways it goes. Seroconversion, perfect. And asymptomatic, perfect, yeah. Prina is right, which is technically, if we're talking about how they present, then they can present with a complication of HIV associated infection. But we're talking when a person's first infected, either they go on and seroconvert, which is what's the time range for seroconversion between infection and seroconversion? What's the usual range of time? Yeah, so like Claudia's saying, 4 weeks or so, so three to 12 weeks, so about a month to 3 months. And what do we mean by seroconversion? Perfect. Once you've started making antibodies to the HIV. So initially, when a person gets infected with HIV and they seroconvert, it can go two ways. They can become symptomatic during the primary HIV infection, or they might just get no symptoms at all. And there are multiple factors which can affect that. One of the big ones is CD8 positive T cells. So those are your cytotoxic T cells. It's basically the more of those you have, the better your progression is. So you will end up still, eventually, if nothing's treated, you will get AIDS and die, but it will just take longer because the cytotoxic T cells are destroying virally infected cells. So you've had that sort of primary phase, your primary HIV infection, which is you get infected with the HIV, your CD4 count drops rapidly and your body starts to react. So you've got your antibodies, which is seroconversion, your cytotoxic T cells. Then what happens? What's, let's say, stage 2 of HIV? Usually. Yep, so your viral load increases and CD4 count. So interestingly, CD4 count when the person's first infected, plummets, and then it might recover a bit, and then it will gradually taper off. But people generally will have a latent phase after their primary infection. On average, this is about a year or two before it progresses to symptomatic HIV or even AIDS. But some people can stay essentially immunocompetent for a decade or so, more even. Again, factors involve CD8 positive T cell count. And Francesco's mentioned one of the things which we use to assess the severity of HIV. Viral load is one of them. Actually, no, you've mentioned both of them. So viral load and CD4. And in my opinion, CD4 is more useful because you might have a massive viral load where if your body's doing particularly well at fighting it off, you might be maintaining your CD4 count. However, you might have a small viral load, but if your CD4 count is really low, that's what's going to be causing the problems. It's not the HIV itself that's causing the problem. Well, it kind of is. It's the effect on the CD4 positive cells. So there is a staging system from the World Health Organization for the severity of HIV. So there's 4 stages, the last of which is AIDS, and they're all centered around the CD4 count. I wouldn't worry too much about them, but the one thing they might come up with in terms of SPAs is they might say this person has a CD4 count of 300. What are they now vulnerable to? So CD4 count. Oh, is that working? Oh, hang on. Sorry. CD4 count generally. Could someone just confirm that they can see the stuff other than course of disease on this slide? Because in my presenting mode, it's not showing them. Oh no, it's there. Sorry, that lagged. So course of disease, in terms of the 4 stages, once the person does have symptomatic HIV, if your CD4 count is 500 or more, that's stage 1, and the symptoms usually mild at this point. So CD4 positive cells should ideally be above 500 cells per microliter. Once you're below 500, you're becoming vulnerable to the more mild end of HIV-associated illnesses, so oral candida, hairy, oral leukoplakia. Stage 3, 350, this is when things start getting quite serious, and that's things like TB, and then below 200 is basically AIDS, and that's where you're vulnerable to everything. So, if we're talking signs and symptoms, what are the symptoms of seroconversion? So we said people could be asymptomatic and people could also present symptomatically. What are the symptoms of seroconversion if someone does present with symptoms? So this is your primary infection. Lymphadenopathy is an important one. Malaise, maculopapular rash, good. What can we say about these symptoms? Would you call them specific symptoms or non-specific symptoms? They're very non-specific. As Claudia is saying, they're all very non-specific symptoms. The acute phase of HIV, so the seroconversion during the primary infection, just as like of any other viral illness, really. Hepatitis A, the flu, it's kind of difficult to tell it's HIV. And you get things like fever, for example, has got a specificity of 80%. So only 20% of people with seroconversion who HIV seroconversion don't have a fever. But then that's still kind of useless because a fever is so common. So it's very difficult, and the way that you're usually thinking about it is from other points in the history, like risk factors. Now, once they've progressed to AIDS, then the symptoms essentially are dependent on whatever infections they've got. So if we think about various sort of manifestations of AIDS-associated illnesses, the respiratory system, what sort of things can we get there in a patient with AIDS? So sort of fulminant HIV. PCP, good. So pneumocystis jirovecii pneumonia. How dangerous is PCP? On a scale of, oh, I can give you antibiotics as a GP to, I'm sending you into hospital and you're going to need to be admitted. Yeah. So Christina said admit, it's exactly that. PCP can become life-threatening very quickly. We won't see it often because since 2014, HIV rates have been dropping. But if someone has PCP, you're a GP and there's someone with pneumonia-like symptoms, and then what's the classic SBA thing for PCP? Desaturate exertion, perfect. So these patients desaturate exertion. You are probably going to be calling the med reg at the hospital and saying, can we admit under medics because I'm worried this person's got PCP. And differential is differential is COVID, yep. And they are more vulnerable to COVID because they're immunocompromised, but PCP is lethal. Tuberculosis is the other big one. It's the biggest cause of death for patients with HIV globally. What about the GI system? What sort of things can they get in the GI system? Perfect. So cryptosporidial diarrhea is a big one. Protracted diarrhea is essentially one of the most common presentations with HIV. Diarrhea of an unidentified cause. You start thinking, wait, is there something more insidious going on here? So cryptosporidium, you can get candida throughout your GI tract, oral, esophageal, anywhere in the GI tract. That's one of the other things with HIV. Over here, most of our fungal infections are pretty, compared to a lot of other countries, the fungal infections we get here are fairly benign. They carry morbidity, but they're not often lethal. So your things like oral gentle thrush, athlete's foot, tinea. When you're starting to see more serious infections, you're thinking this person might have HIV, and Cryptosporidium is a good example of that. That's not something that someone who is immunocompetent should be getting. Okay, so GI. What about the central nervous system? There are quite a few here. So cryptococcal meningitis, again, that's weird. If someone's got cryptococcal meningitis, you're probably going to be testing them for HIV. Cerebral toxoplasmosis, yep, is concerning. And PML, so PML, yeah, progressive multifocal encephalopathy. What's that linked to? What's the causative agent for PML? CNS lymphoma as well is a good one. So CNS lymphomas aren't common. If you see, yeah, so the JC virus, perfect. Well done, guys. So you can also get HIV associated dementia. So you get significant cognitive decline in a young person with risk factors. That can be HIV associated dementia. And that's not an infective thing. It's as in not a secondary infection thing due to a opportunistic infection. It's HIV itself damaging the nervous system. And then there are some malignancies, which are so HIV increases the risk of loads of malignancies: Hodgkin's, hepatocellular carcinoma, the ones which are sort of associated with sex, so anal rectal cancers, head and neck cancers. Why are they at higher risk of head and neck cancers? What do people think? Clue, it's the same reason why they're a higher risk of cervical cancer. Let's see, did someone say? So HPV infection, perfect. Yeah, so oral sex HPV infection is fantastic, which is now the reason, because we know that it can increase the risk of nasopharyngeal carcinomas. It's why boys get vaccinated for HPV in year 8 as well now. Perfect. What are some malignancies that are very suggestive of HIV/AIDS? Kaposi sarcoma, perfect. We'll talk a bit more about that when we do HIV-associated stuff, but this horrific skin, sort of skin cancer. Yep, and it's secondary to HDLV, which is a virus which is an opportunistic infection. You or I should not normally have it, and if we do, we shouldn't have any manifestations. Because they're more vulnerable to getting Epstein-Barr virus, what cancer are they also more vulnerable to? Burkitt's lymphoma, fantastic. And last couple of things, if somebody with HIV was presenting with visual symptoms such as visual loss, as well as sort of a viral syndrome, what are you worried about? These organisms that perfect. So cytomegalovirus, again, these organisms which are generally going to do nothing, but if you're immunocompromised or you're a baby or you're a pregnant woman, they can really mess you up. So some very specific infections which just don't really do much to someone like you or I, but if you have HIV, they can be life-threatening. So talked about the acute phase, which is very much your essentially like general viral syndrome, latent phase, and then anything can happen with AIDS. Right. So here's the important bit for people like you and I. Maybe some of us will go into gum and become HIV specialists, but most of us probably won't. Most of us will end up in hospital medicine or GP. This is the important bit. When do you start thinking that somebody might have HIV and I should probably test them for it? What things make you think this could be HIV? Yeah, risky section. Yep. So there are high risk groups. Perfect. Yeah, perfect. Demographics. Demographics is a huge one. Dense populations. prison, so places like prison, for example, places where are endemic with TB, pneumonia, high-risk countries, Prina said risky sexual behavior and history, things like intravenous drug use. Christina's made the very good point of pyrexia of unknown origin. So diarrhea and pyrexia of unknown origin, you should be testing for HIV. What else? Or anything else? Yeah, so not generally men who have sex with men, but if there is a man who has sex with men presenting with a non-specific illness, then do consider HIV. Who gets in primary care? Who might you offer HIV screening to? Yeah, intravenous drug use is very important. Who might you offer it to? Pregnant women. That's the most important one. Every pregnant woman gets screened for HIV because, again, the consequences can be absolutely devastating. There's the obvious one, which is if the person asks for it. What else? New patients, yep. So if there's a new patient who hasn't been tested, you can offer it, especially in London. Yeah, you're more likely to do it in London than you are somewhere like Kent, absolutely. So I like your thinking, which is if they're going to start DMARDs, mainly it's TB, which they're worried about, but I don't think there would be any harm. Yes, so TB clinic, good. They will test for HIV there. Recurrent infections, absolutely, you'll start thinking, this is a bit weird. If you've diagnosed someone with HIV, who's going to be managing them? Is this a primary care thing or a secondary care thing? If someone's tested positive. Yeah, this is secondary. Why is it secondary care? There's a particular reason for why we do it in secondary care. So initiating management. Yeah, so it's to do with the treatment, and particularly to do with the treatment for HIV. The treatment for HIV, exactly what Francesco said. The treatment for HIV, so your highly active antiretroviral therapy, falls into that distinct but unfortunate group of effective drugs which really suck in terms of side effects. Drugs like clozapine and amiodarone. You have this group in medicine, and you all can think of some based on what we've done so far in rotations. There are always these drugs which are fantastic for what they do, but absolutely suck to take. Lithium, clozapine, amiodarone, rheumatology's got a few. Antiretrovirals are one of them. They are not pleasant drugs to take, which is an issue with compliance. So just to quickly run over the slide, which is basically everything that we talked about. These guidelines are from NICE, by the way. So patients with recurrent infections or with infections that are unusually severe for what they are. So a patient getting really unwell with an upper respiratory tract infection, persistent inguinal lymphadenopathy, things which are related to immunosuppression, but they're not, as of that point in time, known to be immunosuppressed. Something that resembles glandular fever, and then lifestyle is a huge one. So high prevalence areas, men who have sex with men, IVDU, and offered screening in primary care. So it's routine and antenatal care. If they request it, they might request it, for example, if a partner is tested positive. And a very sort of specific one is if you are a GP in an area which has a prevalence of diagnosed HIV greater than 2 in 1,000, so 0.2%. Very specific, but most of those areas are going to be in London and other big cities. And we've said that we don't initiate it in primary care because the drugs absolutely suck. Talked a bit about presentations which are suspicious for HIV. So lymphadenopathy, pyrexia of unknown origin. If somebody comes in and they turn out to have PCP, tuberculosis, who said that? Sonam said TB clinic. People who get TB should be tested for HIV because it's so common in that if you have HIV and you're in an area where TB is common, you are so much more likely to get TB. Remember, TB is not an easy thing to catch. You have to be with somebody for a significant period of time to get TB from them. If they catch it, you're worried they might be immunosuppressed. Your presentations like cryptococcal meningitis, cryptosporidium, cerebral lymphomas, stuff that you've basically already said. If someone presents with that, you're starting to think, HIV. And you can, with some of these, you can essentially treat on the assumption that they've got HIV whilst you're waiting for the test result to come back. Dilemma sort of question, because now we've come to the diagnosis bit and diagnosing HIV, and this is the bit which has the most ethical conundrum surrounding it. HIV diagnosis of HIV is absolutely life-changing, which is why there's a lot surrounding in terms of how it should be done. And HIV testing counselling is a thing that, whilst I don't think has come up in our OSCEs, because I think it would be unfair to expect an F1 to counsel somebody about whether or not they should have a HIV test, it's something that's worth reading up on and the sort of things that you'd be expected to talk about when counseling a patient. You know, we recommend doing a HIV test. Here are the pros, here are the cons, informed consent. In what situations can you do a HIV test on somebody without their consent? In reality, there's basically one. There is one. Best interest and doesn't have capacity, spot on by Bruno. That's literally it. You have an unconscious patient and you do the CT head and you go, oh, that's a bit weird. And then you do an MRI and it's toxoplasmosis and you think, then you're probably going to do a HIV test. Obviously, it's going to be a senior decision rather than the F1 just ordering it. You might be the one ordering it, but you're going to discuss it with your reg at the very least. But because then it's best interest, because it influences treatment, that's practically the only other time, the only time that you would do it. Every other time, it has to be done with informed consent, which should be documented in the notes. It's enough to get verbal consent. Right. So there are two main ways serologically of diagnosing HIV. What are they? Your two options if you want to diagnose HIV. Perfect. And there's the antibody and there's the antigen. And then what was that? Yeah, the P24 antigen. What's the significance in sort of the different ways that you can test for that? So you can test for the antibody, you can test for the antigen. You can test for them together. Let's see. Good. The window period. This is a concept I really struggled with, so I want to make sure that everyone's happy with it before we move on. What is the window period? When people talk about the window period for HIV testing, what is that? Perfect. So Mihir said it, the time it can take between an exposure and being picked up. So, and the problem with it has been pointed out by Francesco. So most of the blood test, like if you take a venous blood sample, venipuncture, the window period is about 4 weeks. What this means is that if you test a patient before 4 weeks have passed, between them being, since they've been exposed to HIV, let's say they had an episode of unprotected sex with someone who's HIV positive, there is a chance, a fairly substantial chance, that you could get a false negative. After 4 weeks, the chance of a false negative is incredibly low. That is the window period. Essentially, all I want you to think of is that during the window period, the risk of a false negative is quite high. Does this mean that if somebody had sex yesterday and says, I want to be tested, we tell them to come back in 4 weeks? Or if they said, I've had sex 3 days ago with someone and I just found out they're HIV positive, do we tell them come back in 4 weeks? Absolutely. So you'll still test them. Just tell them we're going to repeat. We should be repeating this. And what if they were previously exposed, or what if they've just already developed a response, for example, or you can already detect stuff. Just because there's a high chance of false negatives doesn't mean that the chance of false positives is high. If there's a positive, then you treat it. So you'll still test them, but they need a repeat test because the result is essentially unreliable. The thing to remember is that testing where you're taking actual venipuncture and sending that to the lab, the window period is about 4 weeks. After 4 weeks, if it's negative, they almost certainly do not have it. For point of care tests, so that's like finger prick blood and stuff like that, generally it's gotten better to the point where they're roughly around the same, but it can still be up to 90 days. So 90 days is about 4 months. So if somebody's done a point of care test, they should still probably get a blood test. Sometimes people do it because they don't like needles and things like that, but it's really important to emphasize that the blood test is far more accurate than just a finger prick test. And what did we say? If they've got an AIDS defining condition, you're going to test them. And even if they are asymptomatic, we still offer a repeat test 12 weeks later just because of the risk of false negatives. So that's everyone. Is that if anyone is not happy with the idea of a window period or has any questions about it, say so, and I'll want to make sure that all 23 of you here are happy with the idea of a window period because it confused me last year. Okay, so apologies, at the bottom it says should be offered a repeat test 21 weeks. That should be 12 weeks. I'll change that afterwards. But that's what we've talked about. So the importance of the ethical aspect of it, which is talking about this is confidential, but it will go. This will go on your records. Is the point of care. So this is what's confusing now. So the lab test, you can test for both. The point of care test generally used to be testing just for antibodies, which is why it had a longer window, because obviously it takes longer for antibodies to be produced, but they're easier to detect because the antibodies are bigger. Let's see. So with Izzy's one, it used to be that the point of care testing was just antibodies because it's easier to detect in outside a lab because they're bigger molecules, whereas the antigen is quite small. Now there are some point of care tests we can do antigens as well, but generally assume that that the point of care tests are for antibodies, which is why they take longer. And the antigen, which can be picked up much earlier, is the one that you can detect in the lab. So the other way around to what you've said. Why is the retest specifically 12 weeks later rather than any time after 4 weeks? I'll be honest, I don't know. That's the guidance from BASH, so the British Association of Sexual Health and HIV. But I'm not entirely sure. I will look that up. And yeah, it's not. So if you test somebody 2 weeks after they've had an exposure, you know their HIV status basically for the past 4 weeks, essentially. So what is it? Basically, test in. Oh no, I was wait, I think I misunderstood that. Yeah, so if they're asymptomatic, you will test them within 4 weeks of exposure, or at 4 weeks of exposure even. If they're negative, if that test is negative, the first one, then you repeat it 12 weeks later. And in terms of Sonam's one, it's not telling you the HIV status of the patient 4 weeks ago. Well, yeah, basically when you test someone, it tells you the HIV. If it's a 4-week window period, you know the HIV status of the person 4 weeks ago. So if they had sex 2 weeks ago, you don't know that. Yes, to what Christina said, actually, yeah, that said better than I could. That's said better than I could say it, because seroconversion can take some time. Right. If anyone's got still unsure about window periods, say so. I literally do not mind. I will stick around afterwards to explain it even. I just want people to be comfortable with it. Okay. So let's say you're in primary care and someone has HIV test has come back as positive, and you've obviously done it tactfully. You want to do it face to face and talk them through their options. What are you going to do now? So you're the GP in this setting, and someone's been diagnosed with HIV. Yep, so you ask them to come in and you disclose the diagnosis, you tell them about the diagnosis, and now that you've counseled them and everything, what's the next step after that? You've had discussions about contact tracing, stuff like that. Refer them, perfect. So you won't be starting antiretroviral therapy, you will be referring them to a HIV specialist, like Claudia has said. This is actually quite a fast referral. Ideally, they should be seen within 48 hours. So it's 48 within 48 hours of a positive test, they should be seen. It's a really quick referral. That's all right. It's a really quick referral, and at most, it should be within 2 weeks. So it's a lot like a 2 week wait. It's a quick referral. Obviously, whilst in primary care, you'd give them pre and post test counseling. Yeah, so pre and post test counseling is wherever the test is happening. So if you're the GP and you think they need a HIV test, you're the one doing the pre and post test counseling. Or if you're the doctor who's in the walk-in sexual health clinic, you're doing the pre and post test counseling. Absolutely. Christina's talking about pre and post test counseling. Pre-test counseling is basically telling them everything they need in order to be consented. Post-test counseling is telling them what this means for you and what we're going to do now. So things like, look, this is treatable. You will have, with treatment, you will have a practically normal life expectancy. Here are our next steps. So that's the person who requests the test does that, and the person who gets the test result, which is usually the GP or the sexual health practitioner in a walk-in clinic, which is a primary care clinic because you don't need to be referred. So yeah, that's primary care. So you'd give advice on risk reduction strategies, so condoms, safe injection use, so things like needle exchange. So you'd refer them. There are some times where you would refer the patient straight to hospital for admission. So if they're acutely unwell, obviously, we've actually talked about most of them. So if they've got lower respiratory tract symptoms suggestive of pneumonia, you're sending them to hospital because they can die. If they've got symptoms of a CMV retinitis, you're sending them to hospital because CMV has other features and they could die. If they've got neurological symptoms, you're sending them to hospital because they could die. The interesting one is if you've got suspicion of Kaposi's sarcoma within the lung or gut. I'll be honest, I don't know how as GP you would suspect that, but does anyone know why? Does anyone know why you would? Well, actually, yeah. Does anyone know why you would send them straight to hospital? And does anyone know what might give away that they might have Kaposi's sarcoma in their gut? Or yeah, perfect. It's bleeding. So these sarcomas can bleed. So if they've got hemoptysis, hematemesis, PR bleeding, you're sending them to hospital because if they bleed a lot, they will die. So those warrant an immediate referral, and if they're having a serious adverse reaction to their antiretrovirals, they're going to get a referral. What about if you've got a patient who is already diagnosed with HIV? What would make you refer them to a HIV specialist as a routine referral, not a urgent referral? So there's a couple of things. What was being said? So new side effects, yeah, depending on the severity. You might also just call up the consultant and say, hey, this is what's happening. Would you like me to do anything? There are some of the presentations where you go, I should probably be sending you in. It's not going to kill you, but I will send you in now to see them. Pregnancy planning is a really good one. Yeah, so pregnancy planning needs to be discussed with a specialist, really, because some of the antiretrovirals aren't great in pregnancy, others fine. So persistent diarrhea is one of them, where you're thinking this could be because of the HIV. Co-infections, yes, nice one, Christina. So if you find out they're Hep C positive, you're referring them to, and they're HIV positive, you're sending them to a HIV specialist because their medication can be optimized for that. Persistent diarrhea and esophageal candida, so not oral candida, not tongue and stuff, but the actual esophageal one with the dysphagia and the adenophagia. And then there's cognitive impairment, where you're starting to think, are they getting HIV dementia? Okay. Prina, you've mentioned pregnancy. Let's talk about HIV and pregnancy and childbirth. What can we offer a pregnant woman with HIV to minimize the risk of HIV to the baby, being transmitted to the baby from actually 25% to 1%? So a C-section. Do we always have to do a C-section in mothers with HIV? And yeah, continue. So the antiretrovirals need to be continued through pregnancy. Don't breastfeed is a huge one. So mothers shouldn't breastfeed HIV because that's one of the fluids. Triple therapy, yeah. When the baby's born, they should get therapy, short term. And like Liang has said, so let's summarize. 3 things: antiretroviral therapy throughout pregnancy, during delivery, and a short course to the baby. A C-section unless viral load is undetectable, in which case they can give birth vaginally. And don't breastfeed, because you can transmit HIV through breast milk. So those are the 3 obstetrics-related things with HIV. Antiretrovirals to the mother and to the baby. Don't breastfeed, and a C-section unless the viral load is it's not advised. Even if their viral load is undetectable, it's not advised to breastfeed. So it's not like with the delivery method. Even if the viral load is undetectable, they're advised don't breastfeed, which is obviously really hard because breastfeeding has got a lot of this sort of psychological bonding thing behind it. So it can be quite upsetting for a mum with HIV to be told don't breastfeed. What about, so that's the obstetric side. If we talk about the gynae side, what happened to, what's U equals U? Is that undetectable equals? I'm assuming that means if it's undetectable, you basically treat them as if they don't have it. Undetectable equals untransmissible. Okay, undetectable equals untransmissible. Not entirely sure, but I think the guidance is for breastfeeding. Don't breastfeed. I will double check. I could be wrong on that. What was the thing? Oh, with gynecology, with smear tests, what is the guidance with smear tests in a person with HIV? Yeah, so yearly. And what should a person with a woman diagnosed with HIV, or anyone with a cervix, so a trans male, what should they have after they've been diagnosed with HIV? So they should all have a HPV vaccine is a good shout if they haven't had it, but the main thing is colposcopy. So nice guidance is colposcopy after diagnosis of HIV. So without even smear testing, just do colposcopy just to pick things up early. Okay, so that's our management slide. So we've talked about when to refer, how quickly to refer, and when to admit. I'm not going to ask you questions about the drugs used because we don't need to know much about them. There is one important thing to know about HIV drugs, and I will touch on that in a second, but the gist of it with pharmacological management is if they don't take it, they'll die. It's necessary to preserve and maintain life. HIV untreated is lethal. There's no two ways about it. And it should be diagnosed. It should be started as soon as the diagnosis is made. It used to be that you'd start under a certain CD4 count. That is no longer the case. Once they're diagnosed, they should be offered treatment. HAART, so highly active antiretroviral therapy, is 3 drugs. It's usually 2 nucleoside reverse transcriptase inhibitors, and the most common one is tenofovir, and one other drug, and that might be a non-nucleoside reverse transcriptase inhibitor, or an integrase inhibitor, or an entry inhibitor, or a protease inhibitor. I don't bother with any of this stuff because there's a lot of them. The thing that I highly suggest that you do bother with is being aware that the main problem and the main thing that reason we would be seeing them as foundation doctors and so on, or we'd be thinking about them, is side effects. We talked earlier that the adverse effects of these drugs can be incredibly dangerous. And if there are 2 things to take away from this that I'd like you to take away, one is the whole idea of the window period thing, which is why we would wait for, let's say, 4 weeks, or if they were tested before 4 weeks, why we would repeat it. And the other one is, if someone comes in and you're not quite sure what's causing their presentation and they're on an antiretroviral, consider that it is the antiretroviral's fault. Take that away, please, because they cause so much. Off the top of your heads, what sort of adverse effects do you know of in terms of antiretrovirals? Broadly, I know different groups have different side effects linked with them, but generally, what sort of problems do people with antiretrovirals get? Neuropathies, yes. Lipodystrophy, really distressing one. So you're just getting clumps of getting clumps of adipose tissue in weird places, and it's quite disfiguring. What else? Yeah, so nausea and vomiting, diarrhea and vomiting, rash. They can cause a rash. You can get hypersensitivity reactions to them. What about so Lizzie's mentioned neuropathy. They can cause a lot of psych stuff as well, ranging from nightmares and your sleep being messed to full-on feeling depressed and suicidal, or even psychosis has been reported a couple of times. What are some of the more dangerous ones? I mentioned stuff like clozapine and amiodarone earlier. It kind of coincides with those. Think what the dangerous things with amiodarone and clozapine are. Yeah, so they can take out your bone marrow, like Divya and Christina have said. So antiretrovirals can knock out your bone marrow. They can knock out your liver. That's quite a common one. They can knock out your pancreas, which is obviously quite dangerous. Because of insulin resistance, they can cause type 2 diabetes. There's also a bit of a catch-22 with them, which is, yeah, so they can cause heart problems, which is very similar to the atypical antipsychotics. They can cause heart problems, and then some demographics of people with HIV are already at increased risk of heart problems, like intravenous drug users. So they can cause cardiovascular disease. What's the mechanism for them causing cardiovascular disease? The main mechanism. There's a very common side effect of a lot of antiretrovirals. Yeah, hyperlipidemia. Hyperlipidemia is very, very common. And then there's this catch-22, because what do we treat high cholesterol with? Yeah, so statins and fibrates. These drugs very commonly interact with statins and fibrates. So you are advised that if you're considering starting somebody who's on antiretrovirals on a statin, that you should call the HIV specialist. If you want to, after this, go on the page for one of the antiretrovirals and look at the interactions. Tenofovir is a good example. There are so many things it interacts with, from the immunosuppressants to the bisphosphonates to all the NSAIDs, and you will look at that list of interactions, and all you'll see is increased risk of renal toxicity, increased risk of renal toxicity. These things interact with so many other things, and the consequence of interaction is usually that they will ruin your kidneys. So there are some of these drugs which you might well be stopping in AKI as well. So that's part 2 of the takeaway. Part 1 is the window period. Part 2 is if there is if something's going wrong and you're not sure and they're an antiretroviral, consider that it's that thing's fault, because they mess a lot of things up. They could also weirdly cause Fanconi syndrome. Anyone know what Fanconi syndrome is? It is something. Yeah, perfect. It's a dysfunction of the proximal convoluted tubule. So they could weirdly cause that. So if it's not interacting with anything and their renal function's tailing off, you can consider that. Okay. Last thing that weird kidney thing. Yes, that is a adequate summary of Fanconi syndrome. Last thing we'll talk about is pre and post exposure prophylaxis. So pre-exposure prophylaxis is the easier one. Who do we give pre-exposure prophylaxis to? It's basically a combination of 2 antiretrovirals, and it's a case-by-case thing. Who might you give them to? Yeah, so specifically people who aren't going to use condoms or other protective measures, and you go, okay, fine, I really don't want you to get HIV, so can you at least take these pills before and after sex? What's another common one? Think electives, hopefully, for next year. Yeah, partner of a HIV patient is a really good one. So you might offer that offers to them. And one of the other big ones is travel to an area where HIV is endemic and you are at increased risk. So, for example, if you're going on an elective to somewhere like Kenya, you will probably be advised to take PEP just in case you get a needle stick over there. How long can pre-exposure prophylaxis cover you for? Not very, like, you're supposed to take it very quickly. So for example, if it's around sex, you're supposed to take it before and after sex. If so it's literally supposed to be taken just before the exposure. Like, it's not a long-term thing. They're quite short acting. If we talk about post-exposure prophylaxis, so once somebody's had an exposure, how quickly should they get post-exposure prophylaxis? Within 72 hours, perfect. As soon as possible, but it should be within 72 hours. It's about a sort of it's about a 8 to 12 weeks, so 2 to 3 month course, and it's quite a few tablets. It's not a nice thing. It's quite a few tablets, and obviously the side effects that come with them, and they should be tested. No, sorry, I've mixed that up. It's a 4-week course, and you should test the person 2 to 3 months after they are done with the course. And there's quite good guidance for when PEP should be given. I've copied the table. I wouldn't worry about learning it. The important one for us is that if it's a needle stick, you need PEP. That's the most important for us, really. But if we just have, if you want to have a quick look at the table, so it's recommended anal sex if you know the person is HIV positive. It's always recommended. It's not so much recommended for a lot of the other ones, and you'll see if it involves needles and stuff, then it becomes recommended. But it's a lot less than what you might consider, and basically it's only usually done when you're pretty sure that the person has HIV. Would you test before giving PEP, even though it wouldn't be a period? I would see no harm in doing that. Testing, but the chance of a false negative are really high, so you will probably give them PEP. Like, some people might do a HIV test, but the chances are, if you just got a needle stick, you were doing phlebotomy in the ED and you just got a needle stick and it's a HIV positive patient, they're not going to do a HIV test. What is the risk of transmission with a needle stick injury? For HIV, it's really low. It's actually somewhere on PassMed, but it's really, give me a second, I might actually be able to find it. It's 0.3%. Yeah, Oli, perfectly, Jan got to it. It's 0.3%. It's really low, but obviously because of the consequences, you want to avoid that happening. Right. I wouldn't worry too much about that table. The important thing is if you get a needle stick, if anyone gets a needle stick from a HIV confirmed patient, they need PEP. Otherwise, you have the time to look up the table and be like, do you need it? Do you not need it? And it's not an F1 thing. So, to summarize, 2 takeaways. Window period, be happy with what it is. Essentially, if you test during that period, there's a high chance of a false negative, so you can test them anyway, but make sure to repeat the test. And weird thing happening, patient antiretroviral. Of course, it could be a lot of things, just don't discount the antiretroviral if you're a bit stumped as to what's going on. Okay, that makes us finish just on time. Here is the feedback link in the chat, Bob. Any questions, put them there. I will stick around until everyone's gone, basically, if anyone has any questions. And I will correct the mistakes on the slide. I'm also double checking, and it does seem to be, no worries, it does seem to be the undetectable equals untransmittable thing makes sense, but it seems to be that it's still advised not to. Ooh, good thing. So, when do we break confidentiality and tell someone their patient is their partner that a patient is HIV positive? Complicated one, but consent to HIV recently. I wouldn't know about that, Lizzie. I'm sorry. Oh, have I put the wrong link? Balls! I've put the wrong link. Oh no. Can I delete that message? Yes, I can. Sorry, guys. Give me a second. Feedback form. That's the one. Sorry, let me just explain that. Right. So to answer the question about breaking confidentiality, if the person is going to continue, the person is not going to disclose that they have the person is at risk. So let's say they've got a sexual partner, and they're HIV positive, and they're not going to disclose to them. Then generally, SBA wise, you will tell the person, "I'm sorry, but I've got to." It's one of the grounds for confidentiality is risk of significant harm to self or others, which is obviously, we all think of it in terms of psych, but this is one of them. HIV is a significant risk of harm. So if a patient is refusing to tell their partner, and their partner is at significant risk, and they cannot be convinced to do so, and you have a duty of care, that's the hard bit, the duty of care bit, like it's a patient at your own practice, then you are going to inform the patient, unless it is dangerous to do so, and you will break confidentiality. This is the one that is always problematic. I always go with no, which is that even if it's not a patient of the GP practice, then I would still be concerned about the risk to the risk to safety. It's a bit like sort of, to make a parallel, breaking confidentiality because a person with illness has threatened to kill their neighbor who isn't a patient at your practice. You will still break confidentiality, and I think the same applies to here. It is a person at risk. The reason why the GP practice thing is difficult is then, how do I actually get to their partner? And usually that's quite a long thing where you have to contact a sexual health clinic, which they have the expertise for doing stuff like that. But if I had to sum it down to a yes or no answer, does it matter whether the partner is or isn't a patient of the GP practice? No. I'm going to double check the guidance for that, but I'm pretty sure it's no. If I'm wrong, I will post on the group and say, turns out I was wrong, never mind. But based on what I last checked and what I'm pretty sure of, you do break confidentiality because you're putting somebody else at risk. I don't know about the police bit. That's an interesting one. But you do have to tell a sexual partner if you have HIV with detectable viral load. That much is true. If they refuse to, it's grounds for breaking confidentiality. It is a crime. I can't remember what charge it is. If you give someone HIV and they were unaware of your HIV status, that is a crime. But I don't know about you, the healthcare provider, contacting the police and saying this person's refusing. Usually, you will do it through the avenue of a sexual health clinic if they're not already your patient. But we wouldn't be contacting the police. The police would be arresting them if it turned out they infected somebody with HIV. I'm going to double check the partner notification for adults. Fortunately, it's on the BASH website, so I will read through that and get back to you. If anybody else has any questions, then let me know. No worries. But yeah, I'll stick around. Please stay safe. Do you sorry, Prachi, I missed that. Do you retest symptomatic people? As in, if they're symptomatic and then their test comes back negative, is what I assume you mean. I didn't see anything in terms of guidelines about that. I totally would. I absolutely. If I was the GP in that setting, I would repeat the test because, again, I don't want to miss a false negative. But I didn't see anything on the NICE guidance or the BASH guidance about it. But clinical judgment, yeah, totally would do that. HIV notification. No worries, guys. No worries. Take care of yourselves and please stay safe. No worries.